The moment a laryngoscope blade locks into place, a patient's physiologic reserves are tested. If flawed, the operating room becomes a venue for damage control. Consider a 65-year-old female patient with a BMI of 42. She has severe rheumatoid arthritis, type 2 diabetes, and stage 2 hypertension, and she is scheduled for major orthopedic surgery. A surgical intern reviews her chart and clears her for surgery, citing a completely normal resting electrocardiogram. The intern also notes a history of a straightforward, smooth endotracheal intubation 5 years prior, concluding the airway poses no significant risk. For the anesthesiologist, these baseline metrics are a dangerous trap. Superficial checklists often overlook how chronic diseases dynamically alter human anatomy over time. Safe management requires a systematic review of 3 distinct areas: progressive airway deterioration, occult cardiorespiratory deficits, and the risks of concurrent medication. Modern preoperative assessment looks beyond the basic ASA scoring system. It synthesizes multimodal clinical data and maps a patient's dynamic functional reserve to actively reduce perioperative mortality. Effective assessment uses physiological data to quantify risk and implement specific interventions before the patient ever reaches the operating room. We begin with the baseline anatomical threat. Severe rheumatoid arthritis creates a chronic, destructive synovitis that directly degrades the structural integrity of the airway. One of the most immediate dangers is atlantoaxial subluxation. The ligaments supporting the upper cervical spine become lax, and the odontoid peg erodes. A resulting gap of more than 3 millimeters between the peg and the anterior arch of the atlas indicates severe instability. The mechanical consequence of this subluxation is immediate. Applying standard neck flexion during laryngoscopy risks driving the eroded bone into the cervical spinal cord, causing severe compression. This is why trusting historical airway records in patients with progressive disease or advancing obesity is a mistake. Over a 5-year period, joint destruction progresses and fat distribution shifts. The structural geometry of the head and neck today may bear no resemblance to the anatomy documented in the past. Moving to bedside airway prediction, relying solely on a single metric, like the Mallampati score, is inadequate. When predictive airway tests are used in isolation, they yield a high incidence of false positives, misguiding clinical decision-making. The expert approach requires synthesizing multiple structural measurements. We start by identifying a thyromental distance threshold of less than 6.5 centimeters. We then combine this measurement with a Mallampati class of 3 or 4 to evaluate the compounded predictive power. This specific combination of anatomical limits accurately predicts 80% of difficult intubations. Our patient's rheumatoid arthritis adds a final, compounding factor to this calculation: active limitation of the temporomandibular joint. Clinically, this is defined by an interincisor distance of less than 3.5 centimeters, which severely restricts mouth opening. This triad of structural deficits, cervical instability, limited thyromandibular space, and restricted jaw movement, effectively rules out the use of standard direct laryngoscopy. The data mandates a precise, evidence-based alternative, and wake fiber optic intubation strategy to secure the airway without manipulating the cervical spine. Assessing an airway affected by progressive disease requires calculating current geometric constraints. Historical success holds 0 clinical weight. Shifting to cardiovascular risk assessment, we immediately discard the intern's reliance on the normal resting ECG. Resting metrics only prove that a patient's heart functions while they are sitting still. They fail to account for the extreme physiological stress and oxygen demand induced by surgical trauma. This chart details metabolic equivalence, or EMS. This is the standard language for quantifying the estimated amount of energy a patient expends at different levels of physical activity. The clinical benchmark is strict. The inability to climb a single flight of stairs corresponds to the classic symptoms of ischemic heart disease, meaning they rarely exert themselves enough to trigger angina. Recent European guidelines have recognized this, shifting away from arbitrary preoperative time delays, like waiting exactly 6 months after a myocardial infarction, in favor of dynamic, individual testing. Cardiopulmonary exercise testing, or CPX, is the definitive tool for stratifying high-risk patients who cannot demonstrate adequate functional reserve. This graph illustrates the mechanics of the test. It maps exact gas exchange by plotting oxygen consumption against carbon dioxide production, while the patient pedals against increasing physical resistance. During the initial physiological response to exercise, oxygen consumption and carbon dioxide production rise in parallel. But as workload increases, we reach the exact metabolic moment where cellular metabolism shifts. Lactate begins to accumulate, and carbon dioxide production outpaces oxygen consumption. This specific inflection point is defined as the anaerobic threshold, or AT. The mathematical threshold required to safely tolerate major surgery is an anaerobic threshold greater than 11 milliliters of oxygen per kilogram per minute. Patients with an oxygen consumption at AT below 11 face an 18% higher mortality risk following major surgical procedures. This single data point determines the perioperative strategy, dictating the intensity of intraoperative hemodynamic monitoring and the need for postoperative critical care admission. Ultimately, a patient's measured functional capacity provides the most reliable indicator of how their cardiovascular system will respond to surgical stress. Moving past cardiopulmonary data, we must dissect the patient's complex systemic medication chart. We isolate her use of chronic oral prednisolone, prescribed to manage joint inflammation from her rheumatoid arthritis. Chronic steroid use creates a hidden physiological deficit. It causes profound suppression of the hypothalamic pituitary adrenal axis. Because her body cannot generate its own cortisol, the anesthetist must mandate the administration of perioperative intravenous hydrocortisone to mount a stress response to the surgical incision. Next, we evaluate the strict rules governing regional anesthesia in the presence of required thromboprophylaxis. This timeline maps the clinical requirements when a patient is receiving low molecular weight heparin. A strict minimum of 12 hours must elapse between the administration of the heparin dose and the insertion of a spinal or epidural needle. Following the procedure, another mandatory waiting period is required. At least 6 hours must pass before postoperative anticoagulation can be safely resumed. If these precise pharmacological windows are violated, the patient risks a vertebral canal hematoma, leading to spinal cord compression and potential paralysis. The final, often overlooked systemic blind spot lies in undeclared herbal supplements. Supplements like St. John's wort act through enzyme induction. They stimulate hepatic enzymes, which rapidly alter the metabolism and efficacy of standard anesthetic drugs. Similarly, common supplements like ginseng and garlic function as potent platelet inhibitors, actively disrupting normal coagulation. The clinical rule is clear. Mandate a strict 7-day preoperative cessation for all herbal supplements to prevent occult intraoperative bleeding. Pharmacological optimization requires mapping biological half-lives and systemic interactions directly against the exact timing of the surgical insult. Returning to the global view of our patient, we see how systematic data deconstruction neutralizes the hidden risks. Always synthesize multiple structural airway predictors and respect the geometric deterioration driven by progressive diseases. Prioritize dynamic functional capacity and objective cardiopulmonary exercise testing over falsely reassuring resting metrics. Aggressively enforce pharmacological timing to prevent adrenal collapse, neuroaxial hematomas, and occult bleeding. The intern's initial superficial clearance missed these physiological realities and could have led to a perioperative catastrophe. Optimal outcomes are determined in the preoperative clinic, where first principles physiology is used to identify and neutralize patient-specific risks. Before we close, let's look at an area of active clinical debate regarding preoperative medication timing. What is your specific departmental protocol for managing ACE inhibitors or angiotensin II receptor blockers on the morning of a major procedure? Share your guidelines in the comments below.
Thank you so much for watching. Subscribe our channel and stay updated for more lectures.